Now we will proceed further, all the time remembering that all our symptoms arise because the structural changes are reacted to by the neurovascular system. The reaction of the neural system primarily gives pain, and reaction of the vascular system gives claudication. It is as simple as that. So before proceeding, we will talk about the nerves of the intervertebral disc and the functional spinal unit. Basically, the spinal nerve gives two branches, the posterior ramus and the ventral or the anterior ramus. The anterior ramus gives the sinovertebral nerve, which essentially supplies the posterior annulus, and then it gives the skeletal and the muscular branch. The posterior ramus gives three branches. The medial branch supplies the facet joint, as can be seen here. The nerve supplies the same level facet joint, and the lower level facet joint on the medial side, the same level on the lateral side. The intermediate branch supplies the muscles here, and that is the main cause of spasm in a patient who has a sciatic list, because the intermediate branch is irritated, and the lateral branch is mainly cutaneous and also supplies the muscle. So we need to remember this all the time, because all our understanding related to this system, related to symptom generation and relief of symptoms, is based on understanding of the neurovascular response to the changes which are occurring. Now here we will be talking in short about CT guided periradicular injections as a matter of treatment, and this confusion which is there has to be clarified. Now this is a pedicle, and we find that this is the Cambian's triangle, which is the exiting nerve, the traversing nerve, and the superior end plate of the inferior vertebra. This is a triangle in which we go for injecting or treating the disc, the floor of the segment. Now there are some people who also describe this as another triangle where people have been injecting. It is extremely unsafe, should never be done. Why? Because the artery, the segmental artery, and the vein draining this segment is present in this triangle. So it could be the unsafest triangle, and all these sites which have been mentioned should never be used in the treatment of this level. Now this is the transforaminal injection given by taking a needle, going paraspinally and coming similar to a Wiltshire approach, and we go here. Now we must remember here that the nerves are the plexus, and the nerve is in the foramen, the plexus is in the posterior aspect of the psoas here, and this way of coming down is pretty dangerous, because if you go down you may injure the lumbar plexus. It is better to come more laterally and graze the facet and come here rather than outside the foramen. And this is an epidural injection where we go interlaminar and we go next to the dural sac, posterior dural sac, paramedian, but this is blind when it is done commonly in practice. Here it is shown to be done by using a CT, which is okay. So you put a dye, evaluate what it is, and then proceed with injection of anti-inflammatory material, which may be helpful. Now, after understanding all these anatomical relevant factors to the foramen, we also need to know the practical MRI grading of the lumbar foraminal stenosis. Now please remember, I am not talking of canal stenosis here, but just trying to make you aware how the foraminal stenosis has been classified, just to highlight the point that we have changes related to the superior articular process and related to the tissue which hypertrophies here and pushes the nerve against the upper body. May be a formation of osteophyte here, and maybe additional disc herniation. And in many cases, there could be a combination of these two tissues together. That is, there is osteophyte here, there is a disc herniation or bulge, there is a hypertrophy of this tissue, there is a collapse of the disc, there is a upriding of the superior articular process, so the nerve is pushed against the upper pedicle, the body, and this osteophyte pushes it also up, and this soft tissue can push it towards the body. So we need to keep this in mind. This is a part of the stenosis which is commonly seen in the upper zone. Now this zone and the lower zone, etc., has been clarified, but we will be talking more and more about it as the time passes. So we will talk now of the morphometry of the lumbar foramen. This is courtesy my colleague Dr. Ravindranath from Mysore, where they have done a study in Indian cadavers. Now, why they have done it? With academic interest, to assess the severity of the foraminal stenosis and the size of instruments which we can use. This is an intervertebral foramen, as can be seen by a standard illustration, and we can see the boundaries of the intervertebral foramen very clearly marked. This is the body, superior notch, inferior articular process, superior articular process, inferior notch, pedicle, disc. So we already know the boundaries of the intervertebral foramen, and here what has been done is to measure the vertical height and the transverse width. The transverse width is at the level of the disc, the superior notch, and the vertical height is from pedicle to pedicle. And a study involves 10 cadavers where 100 foramina, 5 on either side, both sides 10 cadavers, so total 100 foramina have been studied. And the study of the foramina has been done in the form of measuring the height of the disc, as can be shown here, and the width of the height of the foramen, and the width of the foramen as is shown here. And results are, there is an increase in height of the foramen from L12, which is about 14 millimeters, to almost 17 at 3-4, about 16 at 4-5, and 12 at 5-1. So what happens is, it will increase in the middle part of the lumbar spine, but again decrease lower down. Then there is a comparative study also done by one of our colleagues, Dr. Rajgopalan and Rema Devi from Bangalore, and this says that L12 is 14.6, 3-4 is 15.1, 4-5 reduces to 14.9, and 5-1 further reduces to 12.6. So the height of the foramen goes on reducing as you go below L3-4. Now the width of the foramen at superior notch is L12 8 millimeters, L34 9.2, L5S1 9.9, 2-3 was less, and 4-5 was less. So the width of the foramen was more at 5-1, and it was less somewhere in the middle foramen or around L4-5. Now Campbell's triangle we already talked about, so please remember that we are talking about the upper zone, that is everything lying behind the body, and the width was measured here. The width in the lower foramen is of course very small, because this is between the SAP and the body, and here the superior notch is always wider, being the circular part of the keyhole. Now here the exiting root, that is the hypotenuse, is measured, and the height of the triangle, that is the traversing root, is measured, and here the lower end plate width, that is the base of the triangle, is measured. So to revise, the height of the triangle, the hypotenuse, and the base of the triangle has been measured in our study, and the average dimensions have been, the height is about 12, the base is about 13, and the hypotenuse is about 16. So 12 by 13 by 16. And in case of American cadavers, as we have seen, this is 12 by 18 by 23. So we are dealing with a proportionately smaller foramen, and comparison from Markovic is 12 by 18 by 23, and in our studies it is 12 by 13 by 16. There are a few more studies from Amonu, and the two studies which have been already mentioned, that is one from Rajgopalan and one from Schwartz or Markovic. And this first study talks about morphometric changes in the heights and AP diameters of the canal with aging changes. Now, what we'll do is, in these patients, after we have done the imaging studies, we normally go for investigations to find out if the patient has medical comorbidities. We try to find out the fitness of the system for intervention. We do the lab studies, routine hemogram, ESR, CRP, blood sugar, blood urea, etc. And we do ultrasound to know the post-void residue. In all patients above 65, we do a X-ray, we do a CT scan, we do MRI scan. We also do neurophysiological study as to know the nerve conduction velocity and whether the motor nerves or the sensory nerves are affected and what is the status before, so that we can know what is the status after we have intervened.